What's up, everybody? Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And today I have a super fun guest, one that I actually got an opportunity to listen to on another podcast by Dr. Greg Jones. I've got Dr. Asare Christian, who is a board-certified physical medicine and rehab physician. He is also the founder of, I want to pronounce it right, Aether Medicine in Mainline Philadelphia, where he focuses on cellular health to solve pain and improve performance and Healthspan. He combines a wide range of medical disciplines including pain, cellular medicine, neurorehabilitation, as well as longevity medicine with personalized lifestyle modifications. So if you've been listening for this podcast for a while, you know exactly why he is on the interviewee line today. He has a distinguished practice, and we are going to talk a lot about his education as well as his background and why he is kind of leading the charge in what they call Paingevity. So it's longevity in pain medicine. Are you ready?
I am ready. Yes.
Awesome. So tell us a little bit, you've trained at Hopkins, fellowship at Harvard. I mean, you are a brainiac. Tell us, why this specialty? Out of all the specialties you could choose, why this one?
Yeah, so thanks so much, Lexi, for having me. And I'm honored to be here and have learned so much from your guests as well and all the people, some of those people we've interviewed and from you. So it's an honor to be here. But in terms of pain, this is something that, even when I was finishing residency at Hopkins, I wasn't thinking about doing pain. I didn't want to do pain. So I went to do a non-clinical fellowship. And then part of that, I also got a master's of public health, and I became aware of one of the biggest public health issue we have is pain. And then when I finished my fellowship, I started working at a rehab hospital, which is my background. So individuals that have spinal cord injury, brain injury, stroke, musculoskeletal injury, they all have common to them is pain. So pain was this thing that I was running away from, but somehow it kept showing up. And then I started doing it because that's how what allows my patient to be able to function and to participate in rehab, and then recognize the limitations of what we have in current pain paradigm. So I started educating myself, and subsequently have gotten to a place where now the emphasis is getting people to be healthy. Because what I recognized and knew intuitively was that when people are healthy, pain gets better. People will say, I've done everything else. I go to physical therapy. I've had surgery. I've done this. Nothing is working. But they're still not connecting the dots that what they eat implicates their pain, lack of movement, stress, lack of sleep, imbalances, hormones. All of those things can influence pain. So that's how I ended up here.
Yeah. No, I think it's fascinating, especially because as you and I kind of run in a very similar circle, cellular medicine, peptide therapy, but really how do we round that out into a really robust longevity program for our patients? Pain is one of those things that you have to address it, because it's not just slapping Norco, script on someone. It's you got to look at nutrition, you got to look at the inflammatory foods, you got to look at dysbiosis, hormone optimization. I mean, before we got on the call, I was already kind of digging into your brain, hey, this and this. So can you define for the listeners Paingevity? What does that mean to you?
Yes, and this is a concept that I had this honor to present at a forum, and I was talking about senescence and pain, how senescence is an underlying driver of pain as well as aging. And the whole idea is in this space of longevity, we understand Healthspan and lifespan, right? Mm-hmm. Everybody's focusing on Healthspan, right? Because we want to improve quality of life. And one of the biggest, I guess the difference between Healthspan and lifespan is quality of life and decreased disability. And one of the biggest risk factors for disability is pain, especially as people age. So what I see is that people come to me and they go, I want to be in this program for longevity, but I have all these issues that implicates my ability to exercise. I have all these problems, and people start changing their lifestyle. So the whole idea of Paingevity is living longer without pain. And that comes to a place of looking at the root cause, what's driving pain. And as it turns out, the same cellular processes that drives pain also drives aging. So if we can kind of make this awareness and connect those dots, then it becomes really trying to solve pain as a way to extend Healthspan, or extending Healthspan as a way to also improve pain. So that's the idea.
Yeah, that's great. Okay, so this next question, as you're saying this, it's almost like a two-part question. So take your time. The first question is, like the key factors. What do you feel in all of your experience? What are the key factors that you feel like contribute the most to chronic pain? And then when you have that patient in your office, like, how do you know where to even start? Like how do you connect from point A to point B? So can you like walk us through that process?
It's wonderful. So that's a great question. So chronic pain is complex. And in fact, pain is a protective mechanism. The reason why we have pain, you step on something hot or you touch something that's hot, you move away, your brain tells you, hey, don't do that again. You remember. So there's always a sensory and an emotional component to pain. But then when pain goes on past 3 months, it becomes chronic pain where the same processes that are allowing you to heal or to move away from a specific threat now has changed, and everything has become dysfunctional. So a simplistic way to think of it is like, an alarm system that you walk by, a fire alarm system you walk by, there's no smoke and it goes off. Okay. So when people have chronic pain, there is at the cellular level, there is multiple mechanisms that are going on and keeping the pain in place. And one of the things that I talk to my patients about is really getting them to understand what is the inciting event to your pain, what is the precipitating event, and what is the perpetuating factors of pain. Mm-hmm. And the perpetuating factors is what patients may not be aware of, because pain is a very subjective experience. So the subject, the person experiencing the pain, needs to really understand and to be able to connect the dots. Is it what I'm eating? Is it my anger? Is it something else? So what keeps pain in place from a cellular standpoint, we have neuroinflammation, right? Neuroinflammation is what keep, within the spinal cord and the brain in place. Neurogenic inflammation plays a part. Inflammation itself. So whether it's coming from dysbiosis, coming from stresses, coming from toxins, all of that can keep pain in place. We also have epigenetic changes. In fact, in the context of chronic pain, your body have this descending inhibitory system that regulate how much pain is coming to your awareness or to your brain. That system is actually flipped around, where you have also neurotransmitter imbalances. Instead of having GABA to be increased to decrease pain, you actually have more upregulation of glutamate and substance P. These are all things that are excitatory. Mm-hmm. There is also neuroplasticity. The brain has now learned the pain. Okay, where people can, people with chronic back pain, and they've had it for so long, and maybe when they bend down to pick up something, they always have pain. So even before they do that, the pain, the corresponding chemistry is created. So there's all of those underlying cellular mechanism that drives or keeps chronic pain in place. But in a simplistic version of things, for patients and for individuals in pain, it's what you put in your body. Your nutrition can amplify or decrease the pain, because all of those mechanisms, all of those processes that we're talking about is a function of a cell. Is it an astrocyte? Is it a nerve that's hyperexcitable? Is it a macrophage? Is it a neutrophil? Something that has become dysregulated and not functioning the way it needs to. And that functioning is a function of nutrition, sleep, stress management, exercise. So all of those signals are influencing all of those processes. And beyond that, when it also comes to chronic pain, it's thinking about trauma that people have experienced, because pain is a personal experience that is influenced by various degrees of biology, which is all of those things I've talked about, psychology, and sociology. So all of those things also influence people's experience with trauma. People grew up in a house where they were not taught to talk about pain, then everything is calm. If people have had trauma, their nervous system is hyperexcitable, and that will also keep pain in place. So it's a complex phenomena, and it becomes, each individual, where are they coming from? And then trying to get them to connect the dots. What is keeping me in pain? People get up and say, oh, I don't know why my hands are so swollen today. And then I'll say, go back in the last 48 hours. What did you eat? Who do you talk to? What else is going on? So I know it's a long way to answer the question, but the idea is that there's cellular mechanisms, but if we can get the cells to be healthy with all these signals that we're talking about, pain does get better.
Absolutely. I say so many times, we talked a little bit before we started the call, a little bit about neurotherapy. And when I talk about neurotherapy to patients, I always say it's kind of like this concept, your body keeps the score, right? Just as you said, your body kind of holds that trauma, and it doesn't take much then to trigger all those feelings to come back kind of thing. In your experience with gut health in particular, so we do a lot of GI map testing in our practice. I'm sure you do as well.
Yeah.
And, the amount of patients when we do either like a elimination diet or a low FODMAP diet or an autoimmune paleo diet. And what's so fascinating is we've now taught patients these food equal these symptoms, right?
Yes.
So when we do a reintroduction, the patient is able to identify, I know that if I eat if I eat my yogurt every day, my pain hurts. But if I have it once in a while, it's not so bad. Do you see that same thing? Or are there certain like foods that you're like, every time I try to have patients incorporate that back in there? I always see too, like gluten people like, well, I just want a little bit of bread. I'm like, your body hates it. Why do you keep messing with it? Those lipopolysaccharides, they don't love it. Are there certain foods or anything like from a gut health perspective that you have found in your practice?
Yes, and I love that you bring about gut health. And in fact, if you're a pain doctor out there and is somebody who's interested in pain, if your patient comes in and they have chronic pain and you can't figure it out, check their gut. Okay.
Yeah.
The gut is, in the processing of pain from the periphery to the brain to the spinal cord, you have peripheral sensitization, and then you also have central sensitization. Mm-hmm. Those cells that are sending that signal, pain is basically a signal that goes to the brain, and as it goes up, it gets modulated through nerves and other things and neurotransmitters and all of those things. And the activity of the cells that are modulating how a pain signal is explained. So, for example, in a chronic patient state, where a small signal, you touch somebody, they have this pain like fibromyalgia, right? Hyperalgesia. That central sensitization is all influenced or designed through the gut. Okay. Mm-hmm. So the gut influence, you have all these postbiotic things, butyrate that will, histone deacetylation inhibition, leading to T regulatory cells that will influence those cells to become either hyper or function well. So the gut is so involved in how pain is processed. And in fact, I've had a lot of experience very similar where I had a young guy, had this epigastric pain, chest pain, nobody could figure it out. There were some stresses in his life. And, when people have those type of pain, we classify pain as, nociceptive, inflammatory, neuropathic, and then nociplastic, where, the pain is thought to be created by the brain without any tissue damage. Okay. So this is a guy that's what I thought he had. And then I did a GI map and he has this bug and we treated it. He was having migraines. We couldn't even get insurance to give us, the medicines we need. We solved that and migraine is gone. So the gut plays a huge role in pain, and it can be a trigger or a treatment for pain. So super, super important to focus on the gut.
Yeah, I love that. Out of curiosity, only because again, we do tons, like how many gut tests we've done. Do you see a particular like pattern for what you see, or is there a particular microbe that you're like, oh boy, you know what I mean? Like certain ones that I see that I kind of like, oh, I know that this is triggering this, or like, is there one in particular that you see?
I think what I've seen is H. pylori.
Oh yeah.
So H. pylori, I will see that because I would just manifest with just weird, vague symptoms of visceral pain. So once I see that, and it can also manifest multiple ways. But I've also seen just any type of dysbiosis, inflammatory dysbiosis. People respond differently. If they have some gut permeability issues, that can also trigger. So anything that trigger inflammation can, lead to pain. And I think you asked the question about specific food and nutrition. I kind of same thing. I would tell people to back away from gluten. Gluten is very inflammatory. So they have, anti-gliding IgA. We got to check that out. Dairy is very inflammatory for a lot of people. And once they do that, pain gets better, joint stiffness and all of those things gets a lot better too.
Yeah. Yeah. Connecting the pieces, like, it's so funny. I'm like on question 3 of like my, millions, because this is so fascinating to me.
Yeah.
The hormonal fluctuations that can happen as people get older, we see a decline of testosterone, which can be a huge, benefit for people with chronic pain. The other one that I will see a lot of too is like frozen shoulder and hip pain with the loss of estrogen. Can you speak to kind of a little bit about that? Like, how do you rule that out, rule that in? Like, you just start with a blood test and it's like, all right, sis, you need some estrogen, or like, what's kind of your process?
Yeah, so that's also a great discussion to have because it's very unfortunate that as women go through menopause, they start developing joint stiffness. They start having. I mean, I see this all the time. So, and in the past, I saw them, but I just didn't know how to do this. So it's really unfortunate. But they have all these symptoms: joint stiffness, everything else. Estrogen is going down, testosterone is going down. All those hormones are anti-inflammatory. Estrogen, progesterone, right? So they all are. So, but the issue with estrogen is that it has this dual. It's a little tricky with estrogen and pain. We know for sure testosterone is anti-inflammatory and also decrease the perception of pain experience. But when it comes to estradiol, it depends on the level and the context. So sometimes high estradiol can cause more pain. Low estradiol, for sure, we know can cause a lot of pain. So it's just a moderate amount and trying to find that place. So when somebody come to me and they're having generalized joint pain, other shoulder issues, and they also have the other symptoms, the brain fog, I'm not sleeping as well, and all of those things. And what I see is that people will get put on antidepressants, multiple sleep medications, multiple pain medications. They're still not getting anywhere because the underlying issue is just balancing hormones. So it's a simple thing to do. And we bring all of that in. And just like I introduced, the whole goal is like, let's get you healthy. Let's balance your hormones. When your hormones are balanced, your pain will get better and your sleep will get better and everything else get better. So that's the approach.
Absolutely. No, I think that's amazing. And it's so fascinating how many pain medicine practices have brought in hormone replacement therapy to help better kind of, their patients in pain management. And then not only that, thinking about patients who have been on pain medicine for a long time, unfortunately, that's going to deplete their testosterone significantly, just bottom it out on the ground. And so it's kind of like I personally have a patient where he came to me on, I think 3 times a day Norco. And since he's been doing testosterone optimization, he takes it once a day, which is incredible. So it's crazy how there's such a big, vast difference between conventional medicine and kind of the more integrative, look at the root cause, see what else we can do besides just giving them more pain medicine kind of thing. So no, I think that's fascinating. That's amazing.
Yeah, and there's also, we have tons of literature on this also because the interesting thing is that, so I'm going to be talking at this Pain Week. Pain Week is this huge platform that, pain education and, talking about hormones is one of those categories that they have as like controversial. But even in the pain literature and pain, one of the major journals that we have, they have documented literature of androgen, opioid-induced hypogonadism, right? You're talking about opioid, suppress that. And they took all these men who had like less than, from young people, but they all had like less than 200 and something testosterone, put them on testosterone, randomize it, and pain got better. And then, of course, other things improve: metabolic health, well-being, sexual health, muscle health, and all of those things. So I think definitely the approach and the emphasis here, I mean, if people are in pain management, let's figure out a way to really solve the root cause instead of, signal blockades.
Absolutely. Shifting gears a little bit, as far as what would you say is the biggest kind of misconception about pain and the aging process?
Yeah, so there's a lot of misinformation when it comes to pain. So one, for patients, and in fact, how I started my practice was this idea of just seeing patients over and over, and I recognize that patients have no idea what pain is. Okay, they don't understand pain. Okay, so pain does not mean a tissue damage. That's the big one. So patients have pain, they go, oh my gosh, what's wrong? Something is wrong. Especially when it comes to spine issues, right? Do I have a herniation? Do I have something else? All of those things, right? So it's really important for individuals to understand that you can have pain. Pain can be created by the brain, and pain is actually an output of the brain, okay? So we can cut off your leg and the leg is not there, and you can still experience pain in that leg that's not there. It's called phantom pain, right?
Pain, yeah.
So pain is always an output from the brain. So individuals need to understand that, because what it is people come to me and I ask them, what is your understanding of why you have pain? And they go, it's my L4 herniation. They focus on some imaging thing, okay? So the second thing that I also want people to understand is the fallacy of imaging. When it comes to spine imaging, your imaging doesn't tell us where your pain is coming from. It just shows us structures. Everything in your back can hurt. And in fact, when it comes to identify the source of back pain, we are only able to do that 15% of the time. A lot of the times we don't know where it's coming from because everything in the back can cause pain except like the nucleus pulposa and the spinal cord parenchyma. But even that, with degeneration, nerves can infiltrate and create pain. So it's really hard to kind of go off imaging because that's how people end up getting unnecessary surgery. Well, there's a herniation here. And then the third, thing about pain that I want people to understand is a myth is that, yes, pain can get better. People think, I have the pain. This is what I got to deal with. But it's because of the lack of understanding of the neuroscience of pain, because pain is not only what's happening in the periphery, it's what's happening in the brain, it's what's happening in your life, your social life, all of that influencing pain. So there's some things that we can do to educate people about pain. And then when it comes to, age, this is all due to kind of like, historical perspectives and in medicine and cultural perspective and the under-recognition of how to treat, older people with issues. So we tell you, your pain is because you're getting old, okay? And I say historical, which, you would think, oh, how long ago is that? It's March 2025, okay? I just saw a patient who's older, has had this pain, a patient in Florida. I'm seeing her with, helping with weight management and has had this inflammatory pain that she gets. It comes on, she's inflamed, she's fatigued. The next day, nobody could figure it out, okay? And then she came in and they've been telling her, is that? And I was like, okay, I got you. We're not going to do an extensive. We know this is inflammation, the cellular mechanism. I put it on LDN, and this is somebody who's been dealing with this for so many years. She's been told in her head, I'm stuck with this. Her pain is gone. So there's all of those things. And, there's all this ageism that we also have in medicine, just because we take a very narrow lens of looking at things. Oh, we don't see anything here, so this is what it is. But at the base of it all, it's a cell that has gone bad. And how do we get it to change its polarity to do what it knows to do? So a lot of things, unfortunately, are still happening, even in this contest, right?
Yeah.
Pain. Even from a biblical standpoint, thou shalt bear, Genesis 3:6. Pain, the woman will bear, a child in suffering until we discover anesthesia, right? So there's all of these things that we can do better as providers to really change that paradigm, because there's no law that says that you should be getting more pain as you age. Of course, people experience that because we are not fixing the underlying problems that goes on. And pain can also be healed.
Absolutely. You know how many women I see in their late 50s, 60s, and they tell me, like, I couldn't tell you the last time I felt this good. And it's because, I've gotten their inflammation down. We've cleaned up their diet. We've hormonally optimized them. We've got them on some peptides. It's just like there's this mindset in traditional medicine that once you get older, like I always hear patients say, like, getting old's not for the weak, and I'm like, no, that's why you got to lift weights. That's what I tell them. But it's true. I think a very good kind of 360 view lens can really help patients. I so appreciate that you brought up LDN, because as Leonard always makes fun of me. He's like, oh, Lexi's answer is going to be start in the gut and give him LDN. Like, that's like what I do for many things. Let's dig into that a little bit. So let's talk about maybe like your top 3, like non-pharmaceutical, non-peptide kind of either herbals or maybe manual manipulation or stretching, like top 3 things that you like to kind of recommend to patients for pain.
Yeah. So if somebody have, chronic pain, the idea becomes, one, let's work on what's happening in the periphery. There's always biomechanical deficits when people have pain. Because the signal, you have a sensory signal that goes to the brain, and then you have a corresponding activation of motor signal that inhibits, because it's a protective mechanism. So when you have pain, you're always compensating, and there's weakness. So I always talk about the need to move either through physical therapy or chiropractic care, but even the chiropractic care becomes a passive modality. We want to really strengthen things after that. And then 2, the lifestyle fundamental things. If you're not sleeping, pain doesn't get better, okay? If you're eating junk, pain is not going to get better. If you're stressing all the time, that create a pro-inflammatory chemistry, pain is not going to get better. So those lifestyle things, but things from a supplement standpoint that I like is terracumin. So terracumin is good for modulating inflammation. I always like butyrate, something for the gut. That is also really, really good. I love LDN because LDN is immune modulatory, is anti-inflammatory, and it also blocks your own endogenous opioids. So you make more opioids to control pain. So it's a great one for that type of thing. I also like SPMs, specialized pro-resolving mediators. which are very good for kind of, again, inflammation and the pathway that allows you to heal the LAX versus the COX pathway. I talked about LDN, right? I talked about LDN. I like LDN.
Yeah, I said herbs. We weren't to LDN yet, but you jumped in, but that's okay.
I jumped in. Okay. So curcumin, probiotics, butyrate. What else do I use? And I also try to get on some things that manage stress, because people may have all this stress response that keep cortisol in place. So something that has some combination of adaptogens, ashwagandha, boswellia, L-theanine, magnesium combination. So all of those things are things that I will start with. Then it becomes, patient specific, who's in front of me, what do they need? But the lifestyle things, and then let's get into some things that modulate inflammation, works on the gut, also work on stress response.
Yeah, absolutely. Love that. There's a great blend there's two blends that I use by a company called Designs for Health. One's called Inflammatone, and it's got boswellia in it.
Yes.
Turmeric, ginger. I think EGCG's in there. So it's like you're hitting LOX, you're hitting the COX, you're hitting NF-kappa B. Like I love it because I'm like, cellular pathway. There's this one, that one. And then they've got another really good one. And honestly, I probably use them very interchangeably. They have another really good ArthroSoothe. That was the other one that I was going to say. Those two, it's like, those two are really good as far as the herbals. And then the nutraceuticals, I don't know if you've seen or tried yet, but Regenitides. Regenitides is a capsule that is the combo of BPC 157 and thymosin beta 4. And so that we just got it in our office maybe like 2 weeks ago. And so far we're giving it out. So that looks, that's promising for sure. Do you do much with like capsaicin patches or like Tiger Balm? Like, what are your thoughts on like the topicals?
Yeah, so there's place for the topicals because people sometimes even with the supplementations and other things, if they have absorption issues, they don't get that benefit. So yes, topical lidocaine patch, capsaicin, cannabinoids, topical formulations, Voltaren gel, all of those things have a place for this. And even going back to the supplement, one of the things that I also like to use, especially for musculoskeletal pain, is collagen and vitamin C. So collagen that's hydrolyzed to less than 3.5 kilodalton that you can actually absorb in the gut. And that's very good for immune modulatory and trying to get, cells to calm down. So all of those are good. But yes, topical creams, great option.
Yeah.
And educating patients to kind of get them, especially people that have chronic pain where they feel so helpless. You have options. You can use your topical cream. You can use your, your supplements. You can use your other stuff to try to kind of give you a way to deal with it. Yeah,
absolutely. What about your top 3 maybe peptide options and why? Go.
Okay. Yes. Peptide number 1, no doubt. GLP-1s. Okay. So GLP-1s for pain.
Explain, please.
So GLP-1, so there's GLP-1s, anti-inflammatory. They have all this other pleiotropic benefit, metabolic improvement, muscle health, immunometabolism, right? It kind of corrects that whole aspect of how immune cells are using energy, whether they become an M1 or M2 from a microglia standpoint. So it does all of that. And then it also decreases the weight, where actually we know that from arthritis standpoint, one of the old recommendations from American Academy of Rheumatology was like, if you can lose 10 pounds, you can get pain better. So it's one of those things where we are solving pain, but we are solving so many other things, which is kind of like now the emphasis for me is like, let's figure out compounds or molecules that solve health in a way to address pain. And they've done tons of studies, step, I think it's step 9. So they've done all this semaglutide trials, and step 9 was on osteoarthritis, and that was a great outcome. And of course, we expected that. So I love GLP-1s. I like thymosin alpha-1, thymosin beta-4 combination. That's immune modulatory. So especially people that have autoimmune issues, those are great. And again, you're solving pain and you're also solving immunosenescence. As we age, immune system become dysregulated. That can help with that. And it's not affecting the kidney, it's not affecting the liver, none of those things. I also like pentosin polysulfate, so PPS. PPS is a great one for joint type specific issues, so arthritis of the joint, hip, any of those things. Again, it has a whole inflammatory thing. It works on senescence, it works on mitophagy. It does all of these other pathways to regulate the joint. and even some literature suggesting some disease modifying benefits. So I love PPS. Again, it's also very safe. It has other pleiotropic benefit besides pain. I will also say PDA. So I know everybody loves BPC, but BPC, in my experience, it's good for getting things to heal, but you also need the analgesia. So a lot of times the PDA with the arginate component has a lot more analgesia to me in my experience. Those are, I would say my top, I don't know, I've probably talked about 4 or 5.
It's 5, but that's okay. I was like,
and I also love ARA 290.
I was going to say, did you say ARA?
Neuropathic. Yes.
Yeah. Neuropathic.
That's a great one for neuropathic pain and nociplastic pain. When I started this, I had some patients who were struggling with complex regional pain syndrome, and I was just blown away. This is when I was just getting into peptides. I was like, wow, okay. So, so those would be my top, I guess, 4 or 5.
I love that.
They're small.
I'm mentally like calculating it. So I have a patient who unfortunately suffered an intraspinal stroke during a right knee replacement, and took him a while to figure it out. Was at the Mayo Clinic. Anyway, she's been on every single one of those peptides that you've mentioned, and she was complete paralysis, and now she actually ambulates with a cane. So
that's wonderful. Yeah.
Amazing. She's The other thing I wanted to pick your brain, because you are, Hopkins trained, Harvard trained, is medenkephalin. What are your thoughts about medenkephalin?
So I don't have a lot of experience with that one.
Okay, that's okay. Listen,
So tell me your experience with it.
My mentor is Suzanne Furey, which, my podcast listeners know who she is because I've interviewed her. I've talked about her so many times. And I got a mentorship with her to help walk me through this case with my patient, because I wanted to give her, world-class care. And we have. She's the one who got me into neurotherapy. She's the one who so the reason why we did this is because it acts on those opioid receptors, which can help with chronic pain. It's also got some benefit as far as regenerative properties to it, which I know is your wheelhouse. And so that's why I thought maybe you had used it. What I liked about it is that it's not an opioid, but it acts on those receptors. It's not addicting. I give it to her in an IV. She can drive home afterward. It has helped tremendously. I've actually done, I've layered it with her MSK quaddles that I do with Procaine. And then I'll actually do almost like intradermal injections of the medenkephalin along where her little sacral facets are. And that has been groundbreaking for her, the best thing she's ever done. And then most recently, and so this case I've been working on for 2 years. And like I said, she was not walking to now she just ambulates with a cane, which is huge.
Amazing.
I recently added in a little bit of we have an acoustic wave device. So shockwave, right? Yeah. It also has a smaller little hand piece. And so I did medenkephalin and Procaine, and I used that, and she could not believe how much pain relief she had.
Oh, that's amazing. I have to look into it because I don't use it.
Listen, I got research. I can send it to you.
Yes, that would be wonderful. Yeah.
Amazing. And I'm like, how do more people not know about, this stuff? So medenkephalin, it's not a peptide, but it acts on the opioid receptors without being an opioid. So it's very safe. But yeah, so I was just curious if you'd use that.
Absolutely. I have not used it because I know, you have the opioid receptors and you have mu1 and gamma, and not all of them are addictive. So you can hit different ones to get them there. I just have not, even
but you have a lot of tools. You have far more tools than I do. So this was another one. But you know what's hard though is, and this is when many of our peptides got recategorized, like ARA, we can't do it any. You know what I mean? When a lot of those got recategorized, it's like, well, shit, what else can we do here? And that's where I feel like people like us and Suzanne and Greg, we've got the innovative piece of it because you understand your cellular pathways and how that's going to work. So I was just curious if you knew or tried anything with that. All right. So we talked about your favorite peptides. Okay. So let's talk about what are your favorite compounds. So it's not a peptide, but it's not a nerve. So let's talk about LDN. Yes. You got any other compounds that you like to use for chronic pain?
So small molecules, ketamine.
Okay.
Okay. So ketamine is good. I guess oxytocin is a peptide. And I didn't talk about that because
That's okay.
oxytocin
You
is
can
also
talk
great
about it. There's no rules. There's no rules. Go ahead.
It's good for neuroinflammation. So oxytocin is a good one for pain. Cannabinoids are also great. So cannabis could be used as a compound. I talk about aspirin. What are the ones that are good for pain?
Do you use Fatty 15?
I love Fatty 15.
Yeah.
Yes.
So I've heard very great feedback from patients as far as joint improvement, and it also acts on the endocannabinoid system of the brain as well. So so that one's also really good for that.
Yes. Do you use? Yes, that's a good one. And then there was something else that I was going to talk about. It just skipped my mind. But yes.
What about for you guys, ozone therapy? Is that something that you've done yet, ventured in yet?
Yes, I love ozone, and I today I did prolozone. I mean, I will tell you this: I don't even do as much PRP anymore for pain. Okay, so I have PRP, I have prolozone, I have my peptides. I call them the 3Ps. And then when people come in, because prolozone is just amazing. I was just blown away the results that I get with.
So talk through what is prolozone, because we might have some, because I don't do it. So talk through what it is.
Yes. So one, prolozone is an ozone with a combination of mitochondria nutrients put together. But basically, ozone, as we know, is a medical grade oxygen that we take through a process and it becomes O3. And then we add bicarbonate, procaine, a little bit of steroids, so below physiologic level. So your body makes about 20 a day. You just add about 5 milligrams of it. Okay, the one that we use for injections, which I don't do anymore, is like 40 milligrams. Okay, so 5, and then you use B6, B12, a whole bunch of B vitamins, and you put all of that together and you inject that into a joint, and then after that you add about 20 gamma of ozone to it, and it's just unbelievable. Because a lot of the issues with joints and those places are, they are hypocellular, avascular, they don't have a lot of nutrients. And by getting oxygen there, the ozone will, create peroxides and will carry more oxygen to the site. It will also create a little stress on the mitochondria. So now you make more mitochondria. It's all about energy of the cell. So anything that supports, and then you put all of those B vitamins there, and the mitochondria is happy and everything heals. And it doesn't restrict them from, 4 weeks before they can move, which is what you do with, PRP. It's also one of those things that is not also dependent on the patient's physiology. As you know, PRP is a function of how healthy you are. So I even got to a point where I will have to people fast or do prolonged therapy, prolonged fasting mimicking diet before I do their PRP, because people are full of stuff. And then, that's the same shit that we're going to inject into you. So really, I think prolozone is an underutilized therapy, and as a pain doc, back pain, neck pain, whatever it is. I mean, and it's safe.
Yeah, I love that. So we don't do prolo ozone, so we do procaine with 20 gamma of ozone. So it's kind of like we're missing the vitamins.
You should definitely add the vitamins. It
sounds not too complicated.
It is not, and I can send you the protocol. You mix it together, and then you add a little anti-inflammatory support with just the 5 milligrams of steroids, and it just does amazing for
that sounds great. That sounds great. Might be something I add into the repertoire to my intraspinal stroke. I always say she's like my chicken soup. Like everything I have, I've just added in it, and everything has layered and worked beautifully together. So so that's good. I'm trying to think. I think that's pretty much all the big stuff that I've done with her. But I mean, ozone, metenkephalin, high dose, like all kinds of stuff. So
do you do MAH?
I do not. No, I do not. No. So we just do standard ozone and high dose ozone with UVI light. But I don't do TED-Pass. I don't do EBU, nothing like that. So not yet. Maybe someday.
Yes. Absolutely.
Yeah. All right. Well, I think I've got all of my questions. This was such a great podcast. I know that the show notes on this are probably going to be a popular hit because there's so many great clinical pearls that patients can listen to, as far as a lot of the natural stuff that they can do at home, and then prescribers as well as providers on ways to do it. Where can people find you if they want to either learn from you or hear your next talk, or, either maybe come work with you if they're in that area?
Yeah, so the name of my practice is called Aether Medicine. So Aether Medicine is AETHER Medicine. So you can check us out on our website, www.ethermedicine.com. And then I also do a lot of education and talk about things on Instagram. So it's Aether_medicine. And I'm always out there learning and also teaching. So I'm going to be getting to Vegas soon on Pain Week to talk about the role of estrogen and androgens in modulating pain,
That's
narrative.
amazing.
So something that we need to talk about, because in that context, it's not something that, it's seen as controversial, but definitely something that is needed, because there's all these disparities that we have with women in pain and other things like that. So a bit about myself, I guess that's where I am. And I'm so glad that I got to connect with you and learn from you and share this message with others. Yeah.
Yeah. I'll make sure I'll tag your Instagram. I'll get your website on there, all those good things. So be on the lookout for more educational things that he is doing, because this is some good stuff that nobody talks about. And he is a wealth of knowledge when it comes to all the integrative tools to help people with pain. All right.
Thank you so much. Yes.